health methods can make this a profitable method for providers, even though the cost is reduced to the patient compared to other methods. The financial risk in a capitated system, then, is increasingly borne by the provider, the doctors and the hospitals, in contrast to the insurer in the traditional system. However, what if there's a flu epidemic in my population of 1,000 patients? Say I have 1,000 patients at $10 a month. That sounds like a lot of money. But what if 300 of them suddenly become ill, with many needing hospitalization? Now there's a real risk I would never dream of having as a physician. The financial pool that I have for those patients then is at risk and may be drastically exceeded. This type of problem obviously has to be factored in to the capitation model. I've included 3 additional figures in the appendix for self-study of the steps to gradual incorporation of a capitation plan into a managed care market. Some of these principles might even be applicable to the public health sector in other countries in Latin America. But your feedback on this would be extremely important to me. Basically, every single aspect of the provision of hospital or ambulatory care then is being scrutinized for its cost with both the employers and individual patients, employees that is, joining in various alliances to negotiate for the lowest possible cost for their care. The major desires of the public for their care are free choice of physician, highest possible quality, which includes excellent competence, compassion, and excellent service. He wants easy access to care and, again, low cost. It seems that it's very difficult to provide all of these benefits within the cost restraints of these new managed care contracts. Preventative health measures have been touted as the best way to reduce the ultimate cost and morbidity of illness on society. The relationship between value and cost in an evolving system of managed care is illustrated in a graphic where the assumption is that value can be enhanced without increasing cost. But I'm a bit skeptical about this as a generality. This concept is useful as a takeoff for a debate on students of this subject, however. In the struggle to define the realistic limits of the various variables that go into quality and cost of health care, the consumer or purchaser of care hopes that there's no relationship between cost and quality, but we doctors, of course, believe that that's not always possible. In other words, low cost, high quality, they're at opposite ends of the spectrum. We will make every effort, however, to maintain quality and reduce costs. But to do this was going to require a hard look at every single cost, administrative cost, and other direct costs of our medical care system. The patient, of course, is concerned that his cost for care as a percentage of his income must be reduced. And he hopes that his employer, who is paying for his health premiums, will be successful in several advantageous contracting strategies. The employer, looking out for his worker, seeks selective global contracting for high-cost procedures. He wants these high-tech items to have a fixed cost. He hopes for a primary care focus but yet with broad geographic distribution, as his workers live scattered throughout a city or a state. He wants standardized credentialing of providers, of doctors, monitoring of practice patterns of physicians, increased use of standard medical protocols for care so that everyone does the same thing, selected use of specialists rather than an open door to specialists, and clinical outcome that's based on analysis of the care. That's what's called outcome management, outcome control, management of the actual outcome. We put the patient and the money into the healthcare system. What actually happens to him when gallbladders are removed, when cancer is treated by surgery or radiation? The payer, the employer or the patient who pays for his care, wants to prove that the output, the outcome, is justifiable as far as choice of procedure and also cost of procedure. Other things that are looked for as desirable in contracting, particularly long-term contracts with healthcare providers, include the aspect of free choice, but again, as we've mentioned earlier, this has limitations. U.S. physicians, particularly we specialists who are used to the traditional method of provision of care, have been increasingly disillusioned by the clinical and financial restraints of the managed care system that I have just proposed. The doctors are trying hard to remember their philosophical and ethical pledges to the public while working longer hours for less income. They are frustrated by the administrative paperwork of managed care, the telephone calls that are needed to seek approval for care in advance of providing it, and their ever-increasing practice business overhead while being unable to increase their fees because of the restrictions of Medicare, Medicaid, or private insurance. If you add to that then the geographical restriction of the areas from which a specialist can draw patients, this is extremely annoying. In other words, there is a rule that patients may only seek specialty care within a 30-mile radius of their primary physician. The doctors have increasing anxiety. The more these managed care methods then penetrate their community, but on the other hand, as these fully capitated systems reach the majority of citizens in some communities, and the necessary readjustment of the physician-to-patient ratios occurs, the situation apparently then becomes acceptable. This predicted final realignment of the medical profession has not yet occurred, at least to any great extent in any community. But this system actually is in place more or less through the Kaiser method of provision of care in the U.S. Kaiser is a very large provider of hospitals, employed physicians, and has an extensive penetration into the health market of at least a third or more of most communities, and naturally has been looked at very closely as to how such a system could operate if extended to all parts of a region. In summary of this module, then, we have examined some of the principles of managed care, some of the problems of the variables that contribute to cost, and finally a rather discouraging note by myself that we physicians are concerned that the system may not work. Now, not to end on a discouraging note, however, we will find in the next module the demonstration of a new healthcare system that is being tried at my hospital and in our community, And we're hoping that this model of an integrated healthcare delivery system will even be applicable to public healthcare delivery in other countries as well as the private sector here in the U.S. Thank you.
Thank you, Dr. Nelson. We welcome our visitors, our participants from South America. We apologize that some technical difficulties delayed the beginning of our presentation to South America. We will extend at the end of this for those participants so that we get the full program for them. Let's begin now the first question and answer session. We will try to answer as many questions as possible. Therefore, we ask that only one question be asked per phone call, and that these questions be as brief as possible. You may call the studio directly at the phone numbers or fax which now appear on your screen. We remind you to make your phone calls at a distance from the monitor to avoid feedback. Our first question is a fax from Medellin, Colombia, and it asks, do the principles that you discussed apply to a health system that is completely supported by public funds as opposed to private? Dr. Nelson?
Well, that's a tough question, but I think that it appears that it can, because when I emphasized 20 years or more ago that in the U.S. we had a unrestricted, mostly independent patient, independent financial resource method of reimbursement, it would appear that that would be the exact opposite of the public system, where the government tries to provide a unified system for its patients and for the whole public. Well, I think as we have evolved the managed care model that you see, and what we will talk about further, that the public sector, if I were in Colombia or Venezuela or wherever, the principles apply to the public sector as well, because it's a matter of taking the amount of money that you have for a given period of time, looking at the health needs of the community, taking a look at the resources that you have, and devising the match. So I would submit, and we will develop this as the hour with you goes on, I submit that if you look carefully at these principles, they are absolutely applicable to a public system.
Okay, we have a call now from Tijuana, from the Instituto Politécnico Nacional, CITEDI, in Tijuana, Baja. Welcome. Your question, please.
My question is, what is your opinion about the Mexican Social Security Institute, and why has the medical care system has changed in Mexico if it was one of the best ones used in the world?
Okay, Dr. Nelson?
Well, that's a hot topic, perhaps politically. Personally, I know more about Mexico than any other country beyond the U.S. I've traveled extensively for 8 years, have friends in both the public and private sectors. Now, it is said, and not necessarily by me, that the public sector in the IMSS, in the Social Security system, is floundering, has too many bureaucrats, too many administrators, and that many areas of care are deficient. Perhaps some of that might be true, but the point is that system has an excellent record of good basic care to the Mexican public for decades. I think the challenge now for Mexico is to integrate the private sector with the public sector. And so that, for example, if there are MRI scanners or highly technical facilities available that the public does not have, but yet the private doctors have somehow built, then it makes sense to subcontract from the public sector to the private. But the point is, each of the two segments of medical society, we'll call it, working together so that there is not reduplication of effort and waste.
Okay, we have a question from Guanajuato, the Instituto Tecnológico de Celaya in Guanajuato, Mexico. Welcome. Your question, please.
Buenos días.
Good morning.
En los países
In the Latin American countries, we have very reduced budgets for health care. How could you optimize those budgets?
A challenge.
Well, remember, I'm not a great economist or great financier, a practicing doctor trying to live under the burden of these pressures, just like you. I hate to be too simple, but is not the challenge just to look at the amount of money you have each year, what you have to deliver in terms of basic care, and you match what you're going to deliver to the cost of that delivery? You know how much money you have. You know what you must do for basic care, and then you just do that and that only. If you find that you have got high-priced doctors, high-priced administrators, any, as we say in the States, dead wood, you have to be ruthless. That's what's happening at my hospital. You have to cut every person from the hospital and from the administrative budget unless he's absolutely necessary for your new system of medical care. I think all of us are in for some very tough times. People at the other end of the camera here who know that they aren't essential for their health system should be looking for other work. I hate to be so blunt, but we have to reduce the number of personnel and facilities to the bare minimum that is necessary to give good care.
Okay, a very difficult question. We have a question now from Rio de Janeiro in Brazil, from Key Communications. Welcome. Your question, please.
Muy buenas tardes.
Good afternoon.
Los sistemas HMO serán
The HMO systems
más y más en
have
los
also
Estados
developed
Unidos
more and
y
more
otros
in the United
países
States
de
and other
América.
Latin American
Hoy
countries.
ya podemos considerarlos
Today, we can already
modelo
consider them
anticuado.
as an outdated model. I guess.
Is that, the question is,
Are they outdated?
are they outdated? This HMO model, which is starting in Mexico and other countries, some 20 years behind the United States, you all are hearing in Latin America that it's outdated. Well, I think in part the Health Maintenance Organization model, HMO, tried to cut the costs perhaps too low. No, that's too simple. The public became dissatisfied with the care that they were getting under HMOs. There were long delays for care. They could not see the specialists that they wanted. They could not even call the organization in emergencies and get the care they wanted. So the HMO model in some areas, it's not all bad, but the HMO in some models was not found to be responsive to the public's needs that we outlined earlier. Not enough choice of doctor, not responsive enough when there was a specialized problem. Those are two particular problems.
Okay, we have a question now from the state of Mexico, from Cuautitlan, the Universidad Nacional Autónoma de Mexico, the Facultad de Estudios Superiores in Cuautitlan. Welcome. Your question, please.
Thank you. You've mentioned that nobody should be left without care, even if that person could not afford the care. Why then are immigrants denied this service?
Well, why you are meaning, of course, why would immigrants to the United States be denied service? You see, we are having trouble in the United States providing for our indigent care. 40 million of the over 250 million patients in the United States cannot afford medical care. So the average hard-working worker here in the United States paying taxes, frankly, is upset if he has to spend additional money to take care of immigrants who are indigent when we have not met the needs of the 40 million U.S. patients who cannot afford care. It's an enormous financial burden for us. So naturally, resentment occurs. We're going to try somehow to face that issue. We never turn away a patient at our hospital, for example. Even though we are a private sector hospital in a very nice part of San Diego, if an immigrant from any country comes through our hospital door, he gets care. But as an overall burden on, let's say, society, if there was a large increase in immigrants who had no money for care, we're going to have to deal with that variable, and how we do it is going to be very difficult.
We have a question now from Mexico, from the Comisión Federal de Electricidad, Auditorio Atoyac. Welcome. Your question, please.
Sí, muy buenas tardes.
Yes, good afternoon.
Realmente sorprendente el modelo de atención de servicios
Is it really
integrados de la salud,
surprising, this managed care model? Because over here it looks like the medical service is only interested in the economic aspects. It looks like this new system leaves a large part of the population out, the people that don't have the economic resources, and this could affect the health at the world level, global level. The question is, what are people thinking about doing with the unemployed and the people that are not insured to affront the high costs of treatment and hospitalization?
Now, in the U.S., let's say, public sector or the unemployed sector, we have mechanisms within the United States for the incorporation of unemployed workers into a healthcare system. We call it Medicaid. It is the state, one of the 50 states of the United States, has a budget from the state taxes that support medical care for indigent workers. So all of this system actually is incorporated or blended with the private insurance model, or even with the old age Medicare model. These actually work almost seamlessly in a hospital or outpatient setting. No one is being neglected. There may be greater restrictions in one budget, say for the indigent population, than for the Medicare population at one period of time. But the planners that are devising these so-called managed care methods integrate all of the segments of the population. They're, in a sense, they're looked at as separate revenue streams, but and we're not trying to discuss here that we're economists, we're only interested in the money. We want to give care to everyone. but the hard reality is we've got to think of the money. But the indigent will be incorporated in every one of our plans.
We have a call now from Hidalgo, from Universidad Tecnológico de Tula Tepeji. Welcome. Your question, please.
Sí, bueno, permítame, ahorita le comunicamos.
Just a second.
Sí, ¿por qué la nueva ley
Why
de Estados Unidos prohíbe a los
the new
inmigrantes
law in the United States prohibits the immigrations to receive health services or social security services?
Well, I think we partly covered that in the previous question about, again, restrictions on immigrants. I think it's simply just a method whereby the U.S. is trying to protect itself from an overwhelming avalanche of expenditures for the care of people that, did not originate or were born in the U.S. We're hoping for some orderly flow of people to the U.S. so that our planning can take care of